I'm from Hamilton, Ontario. I did my undergrad at Kamstra University in Health Sciences. During my undergrad, I became passionate about global health and health equity. That's been sort of a focus of mine since then. I did my medical training at McGill, and while I was there, I started doing some work with Tarek Razik in trauma, looking at the validation of trauma scoring systems for low and middle income country settings. During medical school, I also had the opportunity to spend a few months clinically in both South Africa and Madagascar, which is really what affirmed my desire to practice global health. On your first trip anywhere, your number one goal is to make a friend, to find a clinician in the lower middle income country setting that you really connect with. And that you can really develop a long-term working relationship with. So I think there certainly are benefits in terms of exposing high-income country trainees to existing inequities in access to healthcare, but I think that a significant amount of thought and institutional policy really needs to go into making sure that the benefit is indeed bilateral. So I think sustainability is sort of a two-sided coin. So on the one hand, yes, it's important that the things we aspire to achieve in low and middle income countries remain after our lifetimes and after our clinical work is quote unquote complete. But on the other side, sustainability can be used as an argument to not act. You know, if you can't do something quote unquote sustainably, then you shouldn't be doing it all, which I think is problematic in a number of senses. Sustainability was used to exclude surgery from the global health agenda for decades. It was looked at as quote unquote not sustainable, but sustainability really is as much of a political argument as it is a resource one.
You were the lead author in a pretty important paper on the roadmap towards global surgery. Could you just outline some of the conclusions that you come to for that?
So is it interesting, because that paper actually was a bit controversial in one sense, because folks were saying, why are we focusing on high-income country actors? The real action is in low and middle income countries, and so we should be focused on those actors rather than those in high-income countries. And in my mind, there's actually not a whole lot of controversy, because that's what we sort of argue for in this paper, that the most important actors and contributors to global surgery are the clinicians, patients, and policymakers in low and middle income countries. And really those in high-income countries should merely serve a subservient role to those actors in low and middle income countries, that we really need to be sort of humble about what we can and should be aiming for as high income country actors when the real push toward universal access to safe and affordable surgical and anesthesia care has to come from within countries.